Good afternoon, everybody. It's my great pleasure to introduce Dr. Linda Haramati. She came from New York. She's a good friend. She's a professor in medicine and radiology. And she has been in New York for a while. She did her MD at Albert Einstein College of Medicine, then residency at Montefiore. Went to do a chest fellowship at Columbia. She went back to Albert Einstein to do a master's degree. And she has been an attending in chief of the cardiothoracic section at Monty since 1996, but she also has an appointment at Jacobi since 2003. She's the member of the Fleischner Society, you know, those macros that we use? Yeah, whatever she says, we put there. She's a reviewer of multiple journals, including radiology, radiographics. She has 4 research grants. She has spoken in multiple meetings, more than 120 papers, and several book chapters, but most importantly, she's a great mentor. She trained Gary, Emmy, and our Anna Bader. So she sent us her Anna our way. We're very grateful for that. Without further ado.
Thank you very much. I think, is this thing working? Can you guys hear me? That was a little bit of an exaggeration, but I really appreciate the kind introduction. And I also want to thank my partner in crime on this project, Dr. Hannah Milch, who was my resident mentee throughout her residency. We worked on lung cancer screening together, and now she's a breast body fellow at Sloan Kettering, and my colleagues from Montefiore, including our very own Anna, who we share, who contributed to this. I'm going to be talking about the science and practice of image-based screening and radiologist leadership opportunities. And it's a little bit, it's a new talk, it's a little bit controversial, and it's kind of more to stimulate discussion and kind of put it out there. So the outline, I'm going to be talking about the backgrounds of screening, including the risks, goals, and biases, the history of image-based screening, and specifically delving a little bit into the evidence and recommendations for screening with imaging for osteoporosis, breast cancer, abdominal aortic aneurysms, thyroid cancer, coronary artery disease, colorectal cancer, and I'm ending with lung cancer, which is actually the area of my clinical practice. And I'm going to be touching on the challenges of screening an underserved, diverse population, potential harms of image-based screening, and leadership roles for radiologists. So the goals of screening are to target asymptomatic patients at risk. So if they aren't at risk, obviously they have no way of benefiting from screening. And we also want to detect disease when early cure is advantageous. So for example, if you have early diagnosis, but the patient dies of their tumor because it's so aggressive anyway, that's not a target, you know, that can benefit from screening. Or there are some tumors that are very indolent that may not be necessary to be cured, especially in like very elderly population. The goal of screening is to save lives by decreasing disease-specific mortality and, like, more holistically, decrease overall mortality. Screening has risks, including just the risk of false positives, invasive interventions in patients who don't have the disease, the psychological stress of anxiety in healthy people. And so the threshold to institute a screening program should be raised to like a high level of evidence, because it draws asymptomatic people into the healthcare system. That's the definition of screening, is that they're not manifesting like symptoms of the disease. So it's important for us to screen the right patients at the right time in order to see a mortality benefit and a benefit in morbidity. Now, before I get started on these specific types of screening, one of the things to be aware of is that screen-detected disease inevitably represents a more indolent spectrum of disease than the disease that presents clinically. And that's because of certain biases that are intrinsic to screening that I'm going to talk about in a moment: lead time bias, length time bias, and overdiagnosis bias. And the solution to that is randomized clinical trials, where people are randomized to screening or no screening before the disease is detected, and that kind of washes out these biases. So these diagrams were a beautiful article from the New England Journal of Medicine 18 years ago by Ned Patz, a chest radiologist at Duke, and his colleagues. And I'm going to use them to illustrate these points. Lead time bias, in this example, there are 5 patients in the screen group and 5 patients in the control group. One person in each group has the disease. And they developed it at the same moment in time. In the screened patient, the screened patients are screened, let's say, at a regular interval, say once a year, and they're screened, and their disease is diagnosed and confirmed, and they live a certain period of time, and they die. In the control group, they develop symptoms and are diagnosed with their disease, survive a certain amount of time, and then they die. But ultimately, these two groups, the patient develops the disease at the same moment in time and dies at the same moment in time. So what we're measuring when we measure survival group in the screen-detected cancer includes the lead time where the disease is asymptomatic, even though there was no improvement in survival. So this is a pretty easy to understand concept of lead time bias, which is that we diagnosed it earlier, but we didn't impact the process of the disease. And that occurs in some cases of screen-detected cancers or other diseases. Length time bias is actually a much more difficult concept to understand. But just holistically, when we're talking about tumors, but this is also true for non-tumor diseases, the disease is like a spectrum of diseases. So for example, lung cancer, my area of interest, we have the small cell cancer, which is a very, very aggressive tumor that has a doubling time of 30 days. And it grows very, very quickly and metastasizes very early, whereas we have very indolent adenocarcinomas that we know people can live with for many, many years. It may or may not develop into a clinically symptomatic cancer. So that's the mix, say, of lung cancers. So when we screen at regular intervals, say once a year, when you have a very aggressive tumor, the tumor develops and it has a very short asymptomatic period where it's detectable and then symptoms develop. So the period of time that it can be detected on screening is very short, as opposed to the very indolent spectrum of disease, which once it develops, it has a very, very, very long period of time where it is asymptomatic and can be detected on screening. And in fact, you can miss your first round of screening, pick it up in your second round of screening, and still be cured from it. And so what that leads to is when you look at screen-detected tumors versus the clinical mix of tumors, the tumors detected by screening are enriched by indolent tumors and depleted of the aggressive tumors that present clinically as the so-called interval cancers, leading to an apparent improvement in survival of the screen-detected group compared to the mix of all clinically detected cancers. So that's length time bias. Overdiagnosis bias is kind of an extreme version of length time bias. And here in this diagram, we see that in the screen group and in the control group, 3 out of the 5 people have the disease. The screen group is screened at a particular interval, say once a year. All 3 of them have their diagnosis confirmed. 1 of them dies of their disease, and the other 4 die a natural death. In the control group, they're not screened. 1 of them develops symptoms and is diagnosed and dies at that same time as the other patient, and the other 4 die a natural death. So the same number of people actually die from the disease in both groups. But 2 patients in the unscreened group had cancer and were never diagnosed, and it did not affect their natural lifespan. And this is a kind of an example of overdiagnosis, diagnosed with the disease, but they died of something else. And in this case, they weren't diagnosed with the disease, but these are kind of like what I learned about in medical school. Like, for example, every man who's 100 years old has prostate cancer at autopsy, but they died of something else. So it's something that people live with, but they don't die from. So by definition, the indolent cancers were overdiagnosed in the screen group in this example, 2 of them, because those 2 patients did not benefit by any kind of survival or treatment advantage by the diagnosis. And at best, they were overdiagnosed, leading to anxiety. And at worst, they got treated and maybe treated aggressively, and they may have suffered complications of treatment, or even mortality related to their treatment. So this is like this is like the concept of overdiagnosis bias. Segueing on to the history of image-based screening. Image-based screening has had a history of about 70 years now, to the best of my knowledge. And it started in the 50s with early studies on bone density. Then mammo came around in the early 60s. There's actually was chest X-ray screening for lung cancer in the late 60s, early 70s. And then starting in the 90s and 2000s, there was an explosion of image-based screening of like variety of different parts of the body that I will be delving into. And I'm going to introduce to you, I'm sure everybody's have heard of them, the United States Preventive Services Task Force, known as the USPSTF. And they're an independent voluntary panel of experts in prevention, evidence-based medicine, and primary care. And they include experts in behavioral health, family medicine, geriatrics, internal medicine, pediatrics, OBGYN, and nursing. And they make evidence-based recommendations about clinical preventive services without including cost effectiveness in the consideration. And they're important because their recommendations, a grade A or B recommendation, triggers CMS payment that CMS is required to pay if they give a grade B or above recommendation. So they have impact on national policy and our economy, even though we don't have like a national health service. But make note of the fact that there are no radiologists on these panel. And this is like something that I think we should do our best to do something about. So this is their grading system. Grade A, provide the service. There's high certainty that the net benefit is substantial. Grade B, provided there's high certainty that the net benefit is moderate, or moderate certainty that the net benefit is moderate to substantial. C, selectively provided, you know, kind of you can or not, but CMS won't pay for it. D is discourage the service, and I means that there's insufficient evidence to recommend for or against it. So those are the recommendations, and that's going to be the basis for like my talk. Many other societies publish screening recommendations, each have their own goals and biases, and many of them are in conflict with one another. And that's just the way it is right now. So I'm going to use a case-based approach to introduce each type of image-based screening. Then I'm going to discuss the evidence, and then I'm going to cover the USPSTF recommendations. So you should know that these cases, as you'll see, some of them are really appropriate for screening, and some of them are like totally inappropriate from screening. But they are cases that were done in clinical practice for the most part. So here we have a 77-year-old white woman, obese, history of hypertension, diabetes, and she had a DEXA scan that demonstrated osteopenia of the left femoral neck, placing her at a somewhat increased fracture risk. So this is going to be my format. We're going to look at some key studies. Of course, it's going to not include every key study. I'm going to summarize some of the findings of these studies. And the limitation section, this is very important. Every study has limitations. And I'm not going to really be focusing on them, but if you're interested in limitations, you can read about it because there's not 3 hours for this talk. In terms of osteoporosis screening with DEXA, I'm starting with the Marshall study from BMJ in 1996, which was a meta-analysis of 11 cohort studies of more than 4,000 fractures. And what they found is that each decrease of 1 standard deviation of bone mineral density measured by DEXA was associated with an age-adjusted 50 to 150% increased risk of osteoporotic fractures in postmenopausal women. The Canadian study, published in 2005, showed a 30% mortality after the first year of osteoporosis-related hip fracture, with a mortality rate increase associated with older age, male gender, and long-term care residents. The Ontario Health Review in 2008 did a meta-analysis not looking at fractures per se, but at fall risk. And they looked at exercise versus no exercise in the general population, and they showed that exercise is associated with a 33 to 56% reduction in fall-related injuries in the general population, whereas environmental modifications in high-risk elderly reduce fractures by about and falls for about 34%. Moving into this year, the osteoporosis ROSE study, which is a Danish study, randomized clinical trial of 35,000 women aged 65 to 80, who had, all of the women had a clinical assessment, and those with moderate to high fracture risk underwent DEXA. And they found that DEXA group showed 11 to 26% relative fracture risk reduction with respect to osteoporotic, hip, and all fractures. So the bottom line is that osteoporosis-related fractures are a large public health problem with significant morbidity and mortality in the elderly. The prevalence is high in postmenopausal women, although the mortality is highest in men. There's evidence that DEXA reduces fracture risk, but no direct evidence of a mortality benefit from DEXA bone mineral density screening. So what does the USPSTF recommend? For women 65 and older, a grade B recommendation for DEXA screening. And if we look at the radiation, it's a very low 0.001 millisieverts per scan. But if you consider other methods for improving osteoporosis risk fracture, consider exercise, which has a very strong level of evidence for the general population and for those at high fall risks. Environmental modifications, walkers, guardrails, etc. are very, very important. Breast cancer screening. So breast cancer screening is really the most established radiology image-based screening that's done throughout the world and in America. Here we have an 83-year-old African-American woman with hypertension, hyperlipidemia, kidney disease, and hepatitis. She had a screening mammogram that showed a new group of indeterminate calcifications. Stereotactic biopsy yielded indeterminate to high-grade DCIS, and she underwent lumpectomy with plans for radiotherapy. You can make your own determination whether or not she was an appropriate screening candidate. So breast cancer screening, what is the evidence? So the HIP trial was the first randomized clinical trial of more than 60,000 women aged 40 to 64 who underwent annual screening with 18 years of follow-up, and it showed a 30% reduction in breast cancer mortality in the screened group, with the mortality benefit in women 40 to 49 entirely in cancers diagnosed after the age of 50. The Canadian breast trial, which I'm citing next, was a randomized clinical trial of 90,000 women aged 40 to 59 who had annual mammograms and 25 years of follow-up. This is a bit of a controversial trial, but many of these trials have their flaws. They published their 25-year follow-up in 2014, and they showed no reduction in breast cancer mortality. And they cited that 22% of the screen-detected invasive cancers were overdiagnosed, and that is not including DCIS. Lancet Oncology in 2015 published the AIDS trial, a randomized clinical trial of 160,000 women aged 40 to 49, so that's the youngest age set that people usually think about for mammographic screening, and showed a 12% reduction in breast cancer mortality in 10 years. But the mortality benefit disappeared at 17 years of follow-up, which they speculated might be due to improved treatment effect over time. The USPSTF in 2016 did a meta-analysis of 8 randomized controlled trials, and they looked at the number of reduced deaths per 10,000 patients. And what they found is in the youngest age group, it was 3. At the 50 to 59, 8, at the 60 to 69, 21, and at the 70 to 74 age range, it was 12.5, without statistical significance for the youngest and the oldest age range. And they didn't see a reduction in all-cause mortality. So they concluded that the combined data of randomized clinical trials showed small mortality benefit in women aged 50 to 69, but less likely in younger or older women, and that the improved treatment effects, especially seen in more recent days, may skew mortality data, and that overdiagnosis rate is high. Now I'm going to focus a little bit on Welch's paper from the New England Journal of Medicine in 2016, which again, like all of these epidemiologic papers, has its detractors and fans. But I'd like to focus on this graph because I'm going to show you graphs that look like this for other kinds of screening programs as well. This is the incidence of breast cancer per 100,000 women, and this is time, 1975 to 2010, and then we'll get into the granular details of the trial. And what he found based on epidemiologic data is that the rate of metastatic breast cancer remains stable over time. And the rate of breast cancer jumped dramatically about 30% after screening became widespread in the United States. And this is a graph that's frequently seen with overdiagnosis of different entities. And I'm going to get into the granular data in a minute, but one of the problems with overdiagnosis, one of my big areas of research interest is overdiagnosis of pulmonary embolism. And people struggle with it at the individual patient level, because even though the concept of overdiagnosis is real and overdiagnosis really happens, it's very hard at the individual level to know whether or not that's applicable. So basically what Welch did is he looked at population-based data from 1975 to 1979, 2000 to 2002, 2 different intervals, and performed 10 years of follow-up at each interval. And he found that the mortality benefit after onset of screening was about 8 per 100,000, with, according to his calculation, 2/3 of the benefit was due to improved treatment. And for the very smallest tumors, he felt that the case fatality rate was largely due to the biases, lead time bias, length time bias, and overdiagnosis bias. So what's the recommendation of the USPSTF? It's a grade B recommendation for biennial mammography for women aged 50 to 74, and the radiation is 0.4 millisieverts. So this is something that's kind of a regular gig every other year, according to the USPSTF, and as we all know, other societies recommend more frequent screening. What about AAA screening with ultrasound? Here we have a 75-year-old African-American man, current smoker with a history of hypertension, peripheral vascular disease, and chronic kidney disease. Sounds like a perfect screening candidate. Ultrasound demonstrated a 4.5 centimeter infrarenal abdominal aortic aneurysm. He was a poor surgical candidate and continued with regular surveillance after this examination. So what's the evidence for abdominal aortic aneurysm screening with ultrasound? Well, the ADAMS study, published in 1997, was a prospective cohort study of 73,000 veterans aged 50 to 79, and they looked at the prevalence of AAA by sex and smoking status. And that they found that the highest rate of abdominal aortic aneurysms was 4.8 to 6.3% in male current or former smokers. Men who never smoked had a rate of 1.6%, which was equivalent to women current and former smokers, and women who never smoked had a less than 0.5% prevalence of abdominal aortic aneurysm. Scott et al. Looked at 9,000 women with abdominal aortic aneurysm screening, and they found that there was no difference in the incidence of rupture at 5 or 10 years of follow-up for the screened versus the non-screened women. The Danish study looked at 13,000 men aged 65 to 74, and they found a 66% reduction in abdominal aortic aneurysm-related death for screening, with 2% reduction in all-cause mortality, which is not statistically significant. But the reduction in all-cause mortality is an important thing to look at, because I know from the chest X-ray lung cancer screening trials, what they found is that there was actually an increase in mortality for the screened group, because at that time in the 60s, the treatment for lung cancer had a lot of morbidity and mortality associated with it. So even when you diagnose something earlier, you could actually be killing more people with your treatment. So when you show a mortality, and even a non-significant mortality benefit, what you're showing is that you're probably not doing a lot of harm population level by the intervention. And the MASS trial showed similar findings. 68,000 men followed 13 years, 42% reduction in aneurysm-related deaths, 3% non-significant reduction in all-cause mortality. They also looked at the 30-day mortality for elective versus emergency aneurysm repair and found a huge difference, 6% for elective versus 37% for emergency aneurysm repair. So their bottom line is there's a mortality benefit for ultrasound screening for aneurysms for men aged 65 to 74, which is greatest for ever smokers, and no mortality benefit for women. And what's the recommendation? For men aged 65 to 75 who have ever smoked, there's a grade B recommendation for one-time ultrasound screening. Thyroid cancer screening. Now, let me just introduce you to my bias right away. Thyroid cancer screening is the poster child for overdiagnosis. And people don't typically do thyroid ultrasound screening in the United States. So this is a clinical case, but a 37-year-old Puerto Rican woman with a hypervascular left thyroid nodule. She had an FNA that was suspicious. She underwent a hemithyroidectomy, and the pathology was a benign hurdle cell adenoma. So this is an example of a false positive. The patient had a benign adenoma, and yet they underwent surgery, a hemithyroidectomy for it. So talk about poster child for overdiagnosis. This is the SEER database for new thyroid cancer cases and deaths in the United States. And even though we don't really have a thyroid cancer screening program here, we have a lot of imaging in the United States for a variety of indications, including CT scans, and MRIs for neck pain, for trauma, like a lot of chest CTs, image part of the thyroid. So we see a lot of the thyroid, even when we're not worried about the thyroid. So there's been an increase in imaging, even in the United States. And we have a much increase in the rate of thyroid cancer diagnosis over time, whereas the deaths from thyroid cancer have remained stable since 1992. And I'll tell you that they've remained stable over the last 100 years or so. Only about 6,000 people a year die of thyroid cancer in the United States. And half of them are like the anaplastic or medullary type. So the deaths from thyroid cancer are like they're syndromic, they're related to a variety of different things. And like the people who receive thyroid nodules, for the most part, incidentally, are not gonna die of thyroid cancer. The Japanese did a prospective cohort of 152,000 adult women who had screen detected cancer. This was published in 1988. And they found a 98% survival for the screen detected cancers versus a 90% survival for the symptomatic cancers. And it was considered to be, for the most part, related to lead time bias, length time bias, and overdiagnosis bias, because it's screen detected versus clinically. So all those biases related to screening were operative. Vaccarella et al. Looked at population-based high-resource countries for thyroid cancer screening, and he found the most extreme case was South Korea, which had ultrasound screening for women in 50 to 59 since 1999. And we know that thyroid cancer clinically presents increasingly with age, with the highest incidence in the 80s and older. Whereas here in Korea, the peak diagnosis of thyroid cancer was in the 50s, and it was many, many-fold higher than the clinical incidence of the disease. So this is the data for thyroid cancer screening, and the USPSTF last year gave it a grade D recommendation. It recommends against screening for thyroid cancer. What about coronary atherosclerosis screening? Here we have a 54-year-old African-American man, hypertension, hyperlipidemia, poorly controlled diabetes, and a normal stress echo. And he had a calcium score of 229, which is in the 96th percentile for age, sex, and ethnicity. What's the evidence for calcium scoring? So there's the South Bay Heart Watch, published in JAMA in 2004, 1,000 patients with calcium scoring. And they found that it significantly modified, like it was a predictor for MI or cardiac death, if the Framingham risk score was greater than 10%, but not if it was less than 10%. And they found it did not predict mortality. Greenland in JAC 2007 looked at 28,000 patients in a meta-analysis, and they found with a calcium score of 0, there was a very low risk of events in 3 to 5 years, whereas it was 4 times increased if it was more than 0. The MESA study, which is multi-ethnic atherosclerosis study, is a prospective cohort of multiple ethnicities in the United States. 6,700 patients had calcium score, and they found that it was an independent risk factor with at least 7 times increased risk of cardiac events or death in patients with a calcium score of greater than 100 compared with those with no calcium, but no difference among the racial and ethnic groups. The Rotterdam study was a prospective cohort of 2,000 patients, and they looked at intermediate risk patients, men and women, and whether or not the calcium score helped reclassify them into high or low risk. And they found that it significantly improved risk classification into high or low risk for these patients based on 10-year follow-up looking at MI or death. So it is an important risk classification tool. Eisner is the only randomized controlled trial in this evidence table for 2,100 patients who had calcium scoring or no calcium scoring, but they used an intermediate endpoint of risk factor control. And they found superior risk factor control without increased cumulative downstream testing for those who had calcium scoring compared with those who don't. So the bottom line is there's no direct evidence of a mortality benefit from calcium screening. However, it predicts future cardiac events, reclassifies moderate risk patients, and has a high negative predictive value. And this is from the New England Journal of Medicine MESA study. And here we see the low event rate for the calcium score of 0 versus the others. What about the USPSTF? The latest recommendation was from 9 years ago in 2009, and the grade is I, insufficient evidence, to recommend it. And the ACC-AHA guidelines give a class 2B recommendation. So we're awaiting the update from the USPSTF for calcium scoring. What about colorectal cancer screening? Here we have a 55-year-old African-American woman, history of multiple strokes, peripheral vascular disease, and hypertension. As you can see, many of our patients have a lot of comorbidities and might not really be our proper target for screening in these examples, which I guess is part of why I'm putting them forth to stimulate discussion. CT colonography demonstrates an 8-millimeter polyp in the anterior wall of the transverse colon, which was found to be a tubular adenoma at biopsy. So colorectal cancer screening with CT colonography, what's the evidence? So before I get into CT colonography, I'm going to talk about colorectal cancer screening in general, because it's kind of a broad topic. Introducing to you the PLCO trial, which was a randomized clinical trial of screening for prostate, lung, colorectal, and ovarian cancer, 150,000 patients. And for the colorectal part of this, it was flexible sigmoidoscopy versus no screening. And they found a 50% reduction in mortality for distal colorectal cancer, but not from proximal colorectal cancer. And 3 European randomized clinical trials showed a similar effect. The Minnesota colon cancer control trial, published in the New England Journal in 2013, was a randomized clinical trial of 31 patients who were randomized to usual care versus annual or biennial fecal occult blood testing. And they found that fecal occult blood testing, when performed annually, was associated with 32% mortality reduction and biennially 22% mortality reduction from colorectal cancer, although there was no reduction in all-cause mortality. In the New England Journal, I think it was actually even in the same issue, a prospective cohort of 89,000 patients was published looking at both colonoscopy and flexible sigmoidoscopy for overall colorectal cancer mortality. And they showed that both decreased mortality, but only colonoscopy for the proximal lesions, which obviously are not visualized in flexible sigmoidoscopy. And the final two are talking about CT colonography. Pickhart's study in New England Journal of Medicine in 2003 was a prospective cohort of 1,200 patients who had CT colonography and colonoscopy, and they showed that CT colonography is very sensitive for clinically relevant adenomatous polyps, comparable to colonoscopy, and decreasing in specificity with decreasing polyp size. Johnson published a prospective cohort of 2,600 patients in the New England Journal in 2008 of CT colonography versus colonoscopy, and they showed that CT colonography showed 90% of large adenomas or cancers, but extracolonic findings are common, and this is like a thing that we have to deal with CT, 66%, while 16% required additional care. So the bottom line is that CT colonography has shown comparable sensitivity to colonoscopy for clinically relevant polyps, but it's the only screening methods with proven disease-specific mortality benefit are flexible sigmoidoscopy for distal colorectal cancer and fecal occult blood testing. So what about the USPSTF June 2016 recommendation? Okay, notice they got a grade A recommendation, the highest grade for any screening test. For age 50 to 75, colonoscopy every 10 years, flexible sigmoidoscopy or CT colonography every 5 years, or a combination of flex sig and fecal occult blood testing. Harms of CT colonography, 6 millisievert dose per scan on average. Lung cancer screening, this is my thing. I do it, I run a screening program. I have a love-hate relationship with my lung cancer screening program. Here we have a 71-year-old African-American man. He's a heavy smoker. He has a history of HIV infection. And on his baseline lung cancer screening CT, he has this 5-centimeter upper lobe mass on the left. Biopsy revealed squamous cell carcinoma. It was stage 2B. He underwent resection and radiation therapy. So what's the evidence for lung cancer screening? I'm not going to talk about it, but there were 3 trials in the 60s and 70s that looked at chest X-ray lung cancer screening and showed that chest X-ray screening for lung cancer did not save lives. The LCAP study, which actually started in the late 90s and is continuing up until now, is a prospective cohort study. They published the results of 31,000 patients in the New England Journal of Medicine in 2006, and they showed that 85% of the lung cancers diagnosed on screening were stage 1. And this is the flip of clinically presented lung cancers, the vast majority of which are late stage. PLCO trial, which we talked about already for colorectal cancer screening, evaluated lung cancer screening with chest X-ray versus no screening. And they showed, again, no mortality benefit for chest radiographic screening compared with usual care. Because the PLCO trial was ongoing at the time of the planning of the National Lung Screening Trial, the control arm of the National Lung Screening Trial was chest X-ray rather than usual care. And they randomized more than 50,000 patients who were heavy current or former smokers, age 55 to 74, to low-dose CT versus chest X-ray screening for lung cancer. And they showed a 20% reduction in lung cancer mortality and a 6.7% reduction in all-cause mortality, with a very high false positive rate of 23%, including 3.7% of patients had an invasive procedure, many of them for, not for cancer. In Europe, there are a number of randomized controlled trials for lung cancer screening that are kind of ongoing or in follow-up. They're all much smaller than the NLST. The Danish lung cancer screening trial published in Thorax in 2012 looked at 4,000 patients, and they found more early stage cancer in the screen group, 70% versus 33% in the control group. But they didn't observe a mortality benefit. One of the things I learned at RSNA this year is that the Europeans are starting to recommend lung cancer screening continent-wide, coming up soon. And they hinted that with the longer-term follow-up, they've also shown a mortality benefit for CT screening, but it's not all out there yet. So the bottom line is a large randomized control trial found that lung cancer screening with low-dose chest CT saves lives, but it's awaiting replication in other trials and populations. So what's the USPSTF recommendation? It's a grade B recommendation for populations similar to the NLST, except they increased the age to age 80. NLST population was up to 74, and CMS actually decided to split the difference and recommends lung cancer screening for ages 55 to 77, and that's what they cover. What's the harm? Radiation exposure, if we do it every year, 1.5 millisieverts per CT scan, assuming we adhere to low dose technique. Oh, thank you so much. Thank you, thank you. Taking a little lemonade break for our studio audience. So I'm just going to talk a little bit about our lung cancer screening. Like I said, I have a love-hate relationship with it. after the NLST data was published, the clinical services and the radiology department got together, and we thought about, this is such a high level of evidence, a randomized clinical trial, we should really implement lung cancer screening in our population. And I had a lot of trepidations because the lung cancer screening in the NLST, that's a totally different population than the people in the Bronx. So let me introduce you to my patients. It's the most ethnically diverse county in the United States. Half of people for more than 45 years of age are foreign born. So most of them are foreign born. It also has the unhealthiest, poorest, and lowest education level of all 62 counties in New York State, based on length and quality of life, obesity, unemployment, poverty, HIV infection, and other chronic diseases. And you can see that the majority actually of our patients come from Latin America and the Caribbean, but they also come from all over the world. And so they have different smoking habits. Some of them even have different types of tobacco products. They have a lot of, come from endemic areas where there's tuberculosis. So I was pretty much worried about, are we going to see a lot of granulomas and be taking them out? It was really with great trepidation. We set it up right. We used the NLST entry criteria. And we had a coordinator from the beginning who interviewed the patients to make sure they were asymptomatic. And we aggregated our data for the first 4 years. And if you compare our screen population compared with the NLST, you'll find that it's more gender balanced, about half men and half women, as opposed to NLST, which was a little bit more men. We were a little older. We had way more current smokers, 70%, whereas the NLST had less than 50%. And we had every comorbidity was more. So they're generally sicker population. And as we talked about, when you're screening sicker people, they have potentially less benefit from the screening because they have competing risk factors for mortality. But when we looked at our cancer characteristics, so the cancers that were diagnosed in our screening program, cancers diagnosed in NLST, cancers diagnosed at our institution in the screening age population, and from the SEER database, the total lung cancers in the Bronx in 2013, which was the most recent year that we can get the data. What we found is that the rate of adenocarcinoma is kind of similar across the board, almost half of all the cancers diagnosed nowadays, regardless of presentation, are adenocarcinoma. We had 43% of our cancers that were diagnosed in the screening population were stage 1, which wasn't as good as the LCAP study by any means, but the NLST was 49%. So it's a little lower, but it's still, and it's way higher than our clinically detected lung cancers. Only 20% were stage 1. And for the total Bronx, stage 1 and stage 2 was 19%. So we are detecting cancers at an earlier stage. On average, our stage 4 rate was 17%. And how was our performance? Well, our sensitivity and specificity were about 90%. So everything is wide confidence intervals because we have many fewer patients than the NLST. But obviously we had better specificity and lower sensitivity. And we had a much lower false positive rate, and that's because we used the lung rads. We learned a lot from previous experience, and we used the data from other screening trials to help us classify our nodules. And as soon as lung rads became available, we started to use it. And it was really designed to lower the false positive rate of lung cancer screening. And our positive predictive value comparably went up, and our negative predictive value still stayed pretty good. So what about this whole underserved population thing? So there are many different types of underserved populations. Each of them has their own needs and challenges. It could be economic, underserved, racial and ethnic minorities, people from different cultures and different countries, different sense of modesty, different, family structures, mentally ill, transgender. There are a lot of different people that are kind of in this underserved population in general. In our poor urban community in the Bronx, we have a lot of people who do not speak English as their native language or may not speak English at all. We have huge problems with compliance. When we first looked at our data, our compliance with recommendations is only 50%. We're like actively trying to improve that, but it's like, it's a big deal. You know, say come back, they don't come back. One of our patients who were pretty sure positive has cancer. Went like on a prolonged, like 2-year trip back to their country to rest before thinking about like getting the diagnosis. Obesity is a big issue with CT screening because we have to do a higher dose technique, even though we try to adhere to low dose for obese. And we have a lot of this ongoing smoking and who knows what else is going on. Like apparently, just reading in the New York Times, you know, heroin is not like on the upsurge in the Bronx. It's always been upsurged. So the mortality benefits from screening cannot be extrapolated from one population to another without verification. And clinical trials in general, this is a known like thing about research, is they suffer from a healthy volunteer effect. 90% of the patients in the NLST were white, and they had a lot of college graduates. So here's one of our reports from from our lung cancer screening program. Our coordinator takes like a little smoking quit history and puts it into the clinical indications. 40 pack years, currently smokes, no heart condition, not interested in smoking cessation. And luckily did not have lung cancer. And here we see a scout from a CT scan, and we see this, this gentleman has a cigarette lighter in his right front pocket. So like not at all interested in quitting. What are some potential harms of image-based screening? Overdiagnosis, unnecessary interventions, and associated morbidity. This is another one of my lung cancer screening patients, 74-year-old white woman, current smoker. She has a 2.5 centimeter nodule on a screening CT in her left lower lobe. Stage 1A adenocarcinoma. She underwent a lobectomy. 2 months later, she had a terrible headache. She had a glioblastoma, which proved to be fatal. So this is a classic case of overdiagnosis. She underwent physical and psychological stress of a lung cancer diagnosis. It was an early lung cancer. She underwent the unnecessary pain and suffering of a lobectomy, and then she died a year later from her brain cancer. So this is kind of like that prototypical example at the end of those beautiful diagrams from Dr. Patz. Anxiety, radiation-induced cancers, there's a lot of hype about that. We don't know if it's happening or not, but obviously as stewards of radiation, radiologists need to be cognizant of this issue. And you know, society has a great interest in screening because draws in people without symptoms. Screening affects everyone. It draws intense public interest. It gets a lot of press, and some of it is good, some of it's not good, busted, you know, whatever, the whole thing. And widely adopted screening may have limited or controversial evidence or could be applied to populations not studied. Like look at the whole Korean thyroid cancer screening. It turned into like this explosion epidemic of screen-related thyroid cancers that are of uncertain clinical risk. And probably the vast majority of thyroid cancers diagnosed in that population was like in that situation. So I'm a big advocate in this whole idea of educating radiologists in the science of screening. Radiology training lacks dedicated education in screening, and we are very big purveyors in it. We need to have epidemiologic, clinical, and research training. We need to learn about screening targeted populations, suitable disease targets that have treatments that have differential benefit with early detection. We need to understand the metrics necessary to demonstrate quality and efficacy. And we have to understand the biases related to screening. And we also really need to understand our own biases as radiologists and like true believers in imaging. I think that there should be a core curriculum in residency, and I do think that there should be dedicated fellowships. My partner in crime, Hannah Milch, who worked with me on this presentation, did a screening mini fellowship during her 4th year of residency. This is her curriculum. Clinical Research 101 at Einstein, a more advanced in-person course on design and conduct of clinical research with a focus on epidemiology and study design. She was the lead resident in the Montefiore lung cancer screening program throughout her residency. And she did clinical practice and image-based screening and mammo, CT, coronary CT, CT colonography, bone densitometry. And she sought mentorship in the field and did some research. As I mentioned before, she's now a breast body fellow at Memorial, so continuing on in that interest in screening. I want to introduce the idea of the radiologist as an advocate. We advocate for ourselves professionally versus the physician scientist. And advocates encourage more imaging. And I have to tell you my own experience, not in the screening world, but I was on a guidelines panel for pulmonary embolism at the American Society of Hematology. And that's an area of my research interest. And I'll tell you that they considered the fact that I was a radiologist to be a conflict of interest, because we are viewed as advocates for imaging rather than like physician scientists. A physician scientist, with regard to screening, has expertise in screening, is knowledgeable in contributing to the understanding of image-based screening of the right patients at the right time in order to save lives, avoid harm, and avoid unnecessary imaging. So, we want to do the right thing for our patients and not just image everybody. And I think that that's like our general practice, but we need to talk about that. And I do think that these like epidemiologic nuances are something that are not intuitive to anybody, and medical education usually touches on it. I went to school a long time ago, but I only had 2 weeks of epidemiology. But I did go back to school to get my master's in the clinical research methods to help me understand this a little better. With improved training, radiologists will develop the skills and gravitas and really the language necessary to talk to like other physicians interested in this topic, and for us to be recognized as experts in image-based screening and not necessarily just as advocates for our profession. So given the breadth of image-based screening and the complexity of screening benefits and risks, radiologists are a natural position to take on leadership role in medical screening. We need to untangle science from advocacy, and some of this is real, and some of this is really a perception of our field that isn't based in reality, but somehow, some of it, we have to learn how to talk the talk of the people who are doing this research who are not in our field. Proper use of image-based screening would be enhanced by radiologists' expertise in image interpretation, limitations, and also our understanding of radiation biology, which is an integral part of our training. Radiologists with additional specialized training in epidemiology and screening could provide optimal value to this field. We should have a prominent seat at the table in the important scientific study and policy pertaining to screening. We should be on that USPSTF panel, along with other experts in the field. So in conclusion, screening is complicated. It has potential to save lives, but it also draws in otherwise healthy people into the healthcare system with attendant physical and psychological consequences. And like, as you can see from my examples, it also can draw in people who have very little benefit for screening because they have multiple comorbidities that are like significant major competing risk factors for mortality. We should not be screening people who don't have sufficient physical strength to undergo treatment of the illness or the life expectancy to benefit from screening. Many, and it's not us that are ordering or recommending those studies. Many widely adopted screening practices are based on limited or conflicting data with a particular paucity of study of underserved populations. That's my plug for my peeps. Radiologists need a seat at the table. Our expertise in imaging would improve patient care, and I'm advocating for additional training in image-based screening to enhance our ability to take a lead in the study of screening and place ourselves so that we should be involved in policy decision, not just in our own expert panels, but more at the national level. Thank you.